Good afternoon, everyone. My name is Nicholas Bucciarelli. I am a biomedical and clinical architect for OSP. And this is our webinar on digital health, solving the digital access challenge. So let me introduce you to our speaker. His name is Matthew Holt, co-founder of Health 2.0 and founder of SMAC Health and the Healthcare blog, who is going to talk on digital health. So solving the health access challenge through digital health. So let me just start off and say a study conducted in December 2019 shows that 62.93% of primary care health professional shortage areas were located in rural areas, or I must also say in semi-rural areas. So let us find out from Matthew how digital health solutions are bridging gaps in patient care and can help combat these physician shortages. And may I also add on to it, it isn't just physician, it is nursing, it is physician's assistants, and so on. So with these shortages, how can digital health improve the healthcare access? So Matthew, welcome.
Thanks, Nick. I like the way you start with the easy question, right? And before we start, let me just say that I'm not, I don't have like the great academic qualifications in rural healthcare, but I do know that we have significant imbalances in healthcare supply, and we have used technology very poorly to this point, although things have changed during the COVID pandemic, to balance the supply. We've also, by the way, used technology pretty poorly to make things easier for patients and consumers in areas where there are lots of doctors and lots of hospitals, right? So there are lots of places in America. We know there's massive imbalance between rural areas, the wealthy suburbs, some of the well-supplied cities where there are large academic medical centers and lots of activity. Last night the debate was sponsored by Cleveland Clinic, and that's a great example of a place where there's a massive medical complex in the center of a very poor inner city area, essentially. But I would say, we know that we haven't, things like instant connections with specialists and getting people better access to specialty consults, even primary care and what have you, is not great in any way. We haven't used technology well. But putting that aside, what do you do about the rural areas? And many rural areas have been increasingly hit by a couple of factors. One is the general trend in America over the last few decades to have, for essentially money, wealth, and activity to go to the urban and suburban areas. So that's happened anyway. Second has been that some of the rural states that have seen that have kind of been quote unquote being left behind have also not taken the, what I would say, pretty obvious step of taking the Medicaid expansion money. So you've got several southern states which didn't take Medicaid expansion and therefore had less access. When you have a lot of high poverty in those rural areas and you don't say we're not going to take Medicaid expansion money, you're essentially condemning the current providers who are there to having less money, and you see a lot of rural hospital closing, a lot of problems around that. Assuming at some point that gets solved, you still have the underlying issue that you have fewer and fewer providers who want to go to those areas. And I haven't looked into this, but there is a significant amount of the physicians going to those areas have been international medical graduates, predominantly coming from India. And I think the joke is in the South that if you see a person who looks Indian, you say, "Hey, doctor," because you assume they're the local doctor. I haven't looked into what's happened regarding visa applications, what have you, in that area, but I do know in many other areas the current administration, in its wisdom, has made it very hard for people to come in on those kinds of immigrant visas. So I suspect we kind of have a little bit of a perfect storm. So what do you do about it and what can digital health do? Well, the obvious thing is that we're moving towards we're not there yet, I wouldn't call it the revolution, we're moving towards an evolution where you have more and more access to technology that can transport people. And that might be things like some of the recent legislation and payment for things like stroke care in these rural hospitals that's done remotely to major hospital centers. So you show up with a stroke, instead of somebody at the small rural critical access hospital in a rural area who's looking after you, you may have a nurse there who's sort of attaching devices to you, and they're getting advice and consults from a big hospital somewhere. There's a tiny company I know well called Capture Proof, which is doing, using video and photos to do something similar in the Intermountain system, where small rural hospitals in Utah are sending information back over to specialists in Intermountain, and getting advice and back and forth. So you can see that's happening kind of within the hospital world. Obviously, the other area is to take that to the home, and you're seeing the growth of telehealth as a whole. Telehealth is always paid for by Medicare in rural areas, but the growth of private Medicare, private telehealth companies, particularly obviously Teladoc and American Well, who are now public and doing darlings of the stock market, among others, have been, but hundreds of other companies in telehealth, and to some extent remote patient monitoring, with the new codes paying for remote patient monitoring, are helping allow access to those areas as well. The one thing I would say is that this all kind of depends on a decent internet connection, and there are many areas in the US which don't have. We do have, the FCC has been putting money into broadband in rural areas, but we're not Korea. We don't have 100 gig up and down to many of these places yet, in many rural areas. And there have been, during the pandemic, a lot of stories, not so much about healthcare, but about kids trying to do their schoolwork, having to go and sort of sit next to a McDonald's and use the Wi-Fi and what have you. So I think there are places to go, but the goal, I think, should be to figure out how we can use our precious resources of human beings and replace them with and extend them using technology, telehealth, from patient monitoring.
Exactly.
And the one other thing I'd say, which and I'll probably stop at this point because this is a to come factor we may get into later, is of course using AI and using machines and robot and bots to deliver a lot of frontline care. And there's some interesting work being done, not so much in rural America, but in the rural developing world.
Exactly.
Like companies like Babel and others in China. Can you use a bot to sort of be that first line of primary care defense, as it were? Exactly. So I said a lot there, but essentially, yeah, there is hope for changing stuff in the rural areas, and we haven't yet got into things like Walmart's entry into primary care and that kind of stuff. But nonetheless, it's a long way to go.
Yeah, I think just to add on to this before we get into the questions, Matthew, I think what has accelerated this, yes, COVID-19, but Obamacare had basically rearranged, and be it bad, good, or indifferent, I'm not being political, but I've seen forcing the mergers of multiple hospitals and clinics within an area, and the closing of several other ones, particularly hospitals in rural counties, say in upstate New York. So that sort of accelerated the path, I believe, of bringing the need for telehealth. The second item is lack of resources, skilled resources too. But there's another area, working in a clinical industry, and I think I mentioned this during the course of our conversation. It was thrust upon many of the IT organizations within these clinical conglomerates now, I call them businesses, to basically have the knowledge and the skills to know what IT is. In other words, many of them traditionally were medical personnel, just thrust into that role. And so now they have a smorgasbord of legacy systems that they're paying contractors to maintain. They don't know what to do. How do we reduce, become more efficient? And no less, now we have AI coming into the picture. Well, how do we leverage it if I don't understand my infrastructure of content and data because of all these disparate systems? So it's like the perfect storm. So
I'd agree, and I'd actually let me add one more wrinkle, which is the
Yes.
question of who, right? So semi-traditionally, you had providers, primary care providers, small critical access hospitals, and rural providers, right? And then you had a lot of them who are federally qualified health centers, and the like, right? So you have kind of subculture there. And traditionally, I mean, going back several years now, in most states, this was, payers like Medicaid in particular were sort of driving this, and it was kind of the locus of activity was in those physician offices, right, and in the critical access hospitals. And there's a lot of concerns about getting access to them, people have to travel a long way and all that kind of stuff. But that's where it was. And then we start talking about connecting them to bigger facilities, to things like stroke consults and the like. And you got a couple of things going on now. One is that more and more of these Medicaid plans have been put into the private sector, including not just traditional sort of what used to be moms and kids, FTC Medicaid, but now the long-term support services, LTSS, which is, in many states like Iowa and Virginia and elsewhere, has become it's now part of the, it's run by companies like Anthem or what have you. And so they're bringing in their systems to manage this. And then you've also got the concept of well, these health plans are now no longer just paying for stuff, but most of them, Optum obviously is the biggest, or United/Optum is the biggest, but many others are getting into this, are starting to develop their own provider systems, which are not just primary care groups that they may be buying, or other types of hospitals, other types of providers they're buying, but they're also getting very heavily involved into this digital health stuff as well, providing not only telehealth but also Anthem, for example, has got an AI, has done a deal with a company called K-Health, which is a Israeli AI chatbot. So it's not entirely clear who the owner of this function that is like the first line of defense for the patient is. So you mentioned, yes, if you're a small hospital system or a small hospital or a provider organization in rural wherever, and you don't have access to that much technical talent, you've got a lot of complexity to deal with, but it's not entirely clear who's going to manage those patients. And then, I mentioned it briefly, you've got big expansion into healthcare delivery per se by the biggest retailer in the world and the biggest retailer
Amazon,
in rural areas, which is, well, Amazon, but also I was going to say Walmart, because Walmart is getting faster. Right? Walmart is now going to open 35 more centers. And some of these are in suburban areas, of course, but Walmart has a big footprint in the more rural areas. So the question of who is providing care and where it gets provided is all in flux, right? So, and I agree that the strain on the traditional incumbent, rural hospitals, especially with the issue of them merging and being part of a bigger provider system, et cetera, and in some cases being taken up by weird private equity-backed groups who.
Exactly.
There's all kinds of weird fraud and stuff. There's all kinds of stuff going on. But I think, it's in flux, and, you don't want to be political, but you do have to say that this is an area of the country which has been massively, has been underserved and is kind of going its own way. And, probably needs to be, I would say that we need we need the sort of, the Tennessee Valley Authority kind of approach.
Exactly.
Like, how can you bring them back and give them broadband and access to the stuff that people who live in, some of
exactly
like I do already have.
No, exactly. Matter of fact, the last webinar, I was talking to a young lady, Robin, who's very technically schooled. She works in medicine and so on, and she was talking about all the digital technologies, and she must be in her mid-30s or early 30s, but I stopped and I said, because my background is technology and AI machine learning, I said, Robin, with companies like Apple and other companies like Amazon and all these advances, I understand that we will improve health. That is the way to go. But if we get national health care into the US, and if it's run by government bureaucrats, they tend to move slower. The two cultures of innovation versus, we must dot the I's, cross the T's, it is going to crash. And she said, her answer was, we will not have national health care for that reason in the US. because it will just bring down the incentive for introducing new technology. What is your opinion
So
on that?
I actually, I know Rob Fontaine very well, and I think she's wrong. I don't think you necessarily have to have, I mean, so if you look at other countries who have essentially so this gets complicated because what is national healthcare, right? In the UK and Scandinavia, the government essentially owns the hospitals, essentially employs the doctors, and manages that way. And yet you can see Finland, for example, has extremely advanced healthcare, extremely advanced access to their rural areas. They use a lot more technology. They did it somehow. The Germans who have a sort of weird multi-payer traditional system, but with a wraparound of some private insurance and wraparound of some public insurance, but have one fee schedule, and everyone basically, you can't tell when they show up at the doctor's office who they are. It's not like, oh, it's a Medicaid patient paying. They don't have a thing called payer mix that we have here, right? Because they have just introduced legislation, which on a call with some folks in Germany this morning, they've introduced legislation relatively recently to essentially pay for what's called digital therapeutics, direct payment mechanism for new types of digital health delivery. So I don't, you can, there's a lot of stuff back and forth about national healthcare. Now, we may not get national health insurance the way that some of us would like in the US for a bunch of political reasons. You may have noticed last night there was some, I wouldn't say discussion, but shouting about shouting and interruptions in whatever party for a debate that we had.
Exactly.
We had, but I would say that there's a lot of innovation possible within this system. And in fact, I would say probably the most innovative single health system in the world, which has the most digital interaction, is run by 3 major HMOs, and that one is Israel's. So you could argue that they have national health. They have. Everywhere has national health insurance. We're an outlier and an oddity in many ways.
Exactly.
And even within the US, there's been a decent amount of innovation in the VA, which is a social provided healthcare system.
Exactly. Good point.
And there is also a decent amount of activity amongst the federally qualified health centers. They've been a lot of technologies being used there, and they've been. So I don't buy that you don't get technology with national health. What I do agree is that we have yet to figure out if we are going down a market-based path where people like Walmart, Amazon, and others are going to be providers and doing healthcare in innovative ways. We have yet to figure out how that fits with kind of our standard Medicare fee schedule, which I would agree is very stultifying. And
exactly. That's why many doctors have dropped it. But it's interesting because I did work for National Healthcare Service in Great Britain with a customer relationship management system, and I did not see some of the things that have been cited in the debate in the U.S. But the specific questions I have for you, and again, Matthew, thank you for taking time today. My first question, and which I thought was very interesting, studies have shown that digital sedation could replace the anxiety medicine midazolam in 80% of surgeries carried out under local anesthetic. Do you see patients adopting digital sedation, and how effectively can these platforms disassociate patients from their symptoms?
So you're asking the wrong guy. There's a guy called Brendan Spiegel down at Cedar Sinai who was the expert on sort of the impact of VR on health. The answer is it's really on medicine and what you do. It's really early days, but there have been some studies showing that you can disassociate people from pain. And I think in China they use acupuncture to do that. You don't actually use anesthesia. So it seems a stretch to imagine that Americans would not take anesthesia, for surgery. I've had a decent amount of surgery on knee surgery. I'm a snowboarder and I snowboarded into a tree, so I had a lot of knee surgery. And I was awake for it. They stab your knee a lot, and they give you a lot of surgery. They give you a little bit of fentanyl or something to put you out, and they wake you back up, and you can see the surgery. I should watch the surgery on the TV. What was going on? It seems a bit of a stretch to think that our current culture will leap over to that anytime soon. But I think that the role of things like VR and different types of technologies to distract that are going to come. And if you think about the other ways that we're using things that weren't really thought of for healthcare more broadly, for medical care more broadly. You know, you now are seeing things like psilocybin, you know, the magic mushrooms, essentially the drug of magic mushrooms, now in advanced trials as a potential, you know, cure for all kinds of different sort of, you know, mental health, behavioral health issues. Same PTSD, and you're also seeing the same thing happening with the growth of ketamine, which used, you know, the horse tranquilizer used as a club drug, and now J&J is actually a real drug, which is essentially ketamine, which is out on the market, you know, and a lot of use of that for things like depression. So I can imagine we are going to be more accepting as a culture of different ways of treating this. Do I think that anesthesiologists are going to go out of business and be replaced by VR bots anytime soon? Probably not yet.
No. It'd probably be a blended.
But I would say Brendan Spiegel at CEDAS, he's doing a whole bunch of stuff. He's written a book about this. He's doing a whole bunch of clinical trials, and we'll know much more about this and get it validated one way or the other, you know, in 4 to 5 years.
Exactly. I know from my own experience in the U.S. military as a consultant for the DoD, they basically have been doing that sort of sedation, particularly when soldiers are taken as POWs. So how can they withstand pain?
Right.
The second question, what kind of digital health solutions will help uninsured and underinsured Americans get better access to quality health care?
I think it's very similar to the first question about rural care, right? Which is, you know, there are a number of solutions coming on which will help them do a combination of self-service and access to cheaper, better care. So some of this, you know, some of this is what can you help people deal with, and whether it's the self-service of them looking stuff up, of bots of getting better information about their care. That's one area. The other area I think would be technology that is designed to help them access better and cheaper care, and we got a great example of that, which has just gone public, which is GoodRx. Right, so GoodRx is a company now in the specific area of drug pricing, but to help you find, you know, the better drug price, because help you navigate the maze of drug pricing and drug rebates and coupons or whatever. And essentially now you can look it up on an app, walk into any drugstore and get the best price. And you know, those guys have done very, very well for themselves. The company's now worth more than Cardinal Health.
Yeah. and they're getting into telehealth too. Some of their
and they're going to add the fact that I can get you a cheap telehealth visit consult to get that. And there are many others in that little area of. I mean, that's a tiny part of their business now, but there are many others in that area of, and it's a little bit early stage now. But can we get you cheaper care by doing sort of telehealth access to drugs? So that includes companies like Roman and Rory for boys and girls, I guess. Hims, Lemonade, Nurex, or Nurex, I think it's now called. I can't remember how to pronounce it. But you know, can you access that? And I would say that, you know, some of these technology accesses is basically telehealth getting you to medication that gets delivered by in the mail, if the mail is still working. Some of that is to my mind a sort of technological replacement for driving, going to an expensive doctor, going to a pharmacy. You know, it's like a new delivery system, kind of like Uber replacing a taxi, and it's cheaper for a number of reasons, but not least because they're using more technology and fewer human beings, and they're putting less onus on the patient. Now that doesn't cover everything, but that helps them cover some things.
Yeah, excellent points. The next one has to do with digital therapeutics as a relatively new category of digital health that is gaining recognition. How is it different from digital wellness applications, and what is the potential in improving population health?
You ready for a rant?
Go ahead, Matthew. Well, I'm learning a lot from you.
So there have been, since the start of, I've been covering digital health basically since 1993, and started out with, can we get people there? Can we get people their data, their records, right? Can you get and it's kind of, or can you get them access to content, and can you marry those two things together? And now it's, can you get them programs that are somehow, similar to the ones they would have got from a professional. So there's now been a group of these which have said, okay, we can now do a program that is a digital-based program which may measure you using your phone, but may give you information and give you prompts and tell you what to do, that is somewhat similar to what a health professional would instruct you to do. So it's like, almost like we'll give you a book, but we'll do more applications, more measurements, and we'll put people through these programs, and we'll say there's a clinical validation they actually work. And some of them use just the program alone. Some of them use the program and a coach. Some of them use the program and a pill. But the goal of all of these things is to say, can we have you, the patient, take action, take an intervention which is basically being delivered to you by a phone or by a website. And it may have a human, it may have a bot, it may have just be instructions, it may be measuring you and reacting to you. And it's been used probably to great effect within areas such as mental health, where I think like CBT and others have been growing. And then increasingly being used, for specific subparts of different conditions like schizophrenia or whatever else. So I think this is a natural evolution of how health and medicine should go, right? Because essentially it's the same kind of thing that, you came and saw a doctor said, do your exercise, change your diet, take these 2 pills, call me in the morning or call me in 2 months, right? And then talk to a nutritionist who will help you with this, talk to a counselor who will help you with that, etc. There was this kind of, it just wasn't applied properly in a broad, systematic program. So I think it's great to do that, and I think it has great improvements. And of course, much of this is self-service and therefore can be cheap. It doesn't involve an expensive professional. What I don't like about digital therapeutics is the approach that several of the companies in the space have taken, where they basically are going, well, what we like about the concept of a therapeutic or a drug is that we can get a patent on the particular thing when we show it works. And then we can charge a lot more money than the thing costs us to produce, and we can make it very profitable. And I've seen several digital therapeutics companies essentially take a program, in some cases some of them actually bought other companies' programs, have turned around, have put them through some kind of trial, are working for FDA validation of the digital therapeutic with the intent of charging more like drug prices than software prices. And that to me is completely the wrong way. We shouldn't be doing that. We should instead be saying, how do you incorporate these kinds of programs, which are delivered by technology, into the mainstream of healthcare? And by the way, why we should be looking for the advantages of the software brings, which is you can do a lot more scalably at a lower price to more people.
Exactly.
With software. We shouldn't be saying, how can I build this mystical black box digital health intervention, call it a therapeutic, get some kind of FDA pixie dust validation, get a patent on it, exclude other people from doing it,
and then
try to make it like a drug. Because the way the drug companies have priced their products does not serve the American public well, if you ask me. Now, people will argue about innovation and what have you, drugs, but if you ask me,
no, you're right.
We shouldn't be heading down that path. But the influence of money being what it is, clearly people are going to try and do that.
It's a strong,
If you want me to really name names, so Pear Therapeutics has gone down the list. When they basically set up to start doing what they're doing, they went back and they tried to find studies that they thought, they went and looked at all these digital intervention studies, and they found the ones they thought they could get through the FDA and get some kind of patent exclusivity on. That was what they were looking to do. And then as a financial game, they then pursued those studies and built these products off them, with the goal of having them be defensible like a drug, be able to charge for them like a drug. Now, I don't think in the end payers will pay for it, what the drugs will pay, but that's the path they're heading down. And to me, that's not the way that we're going to, get the full benefit of this new kind of technology to the maximum amount of people. It might be the way those individual companies make a lot more money, which
exactly.
Hopefully not. Hopefully they get, they don't manage to get what they're getting to, but. We do
Exactly.
have now a Digital Therapeutics Alliance, which is promoting this, and I'm probably the most person who shouts the most that this stuff doesn't exist. But anyway, that was the rant.
Well, no, Matthew, I couldn't agree with you more. While many healthcare providers agree that digital health solutions enhance patient experiences, one research group reported that the time saved by using health applications can add up to significant ROI for providers too. Would you find that to be a valid statement?
I mean, it depends. I think what you mean by, which application, I don't know, for the study you mentioned, which applications they were discussing, because there's a lot of, what is, quote unquote, what is digital health and what is digital health applications. So I think there's a lot of ones that are now fairly widespread, which have been shown to be in a big increase in efficiency and effectiveness. So I would take a very simple like Freesia, which was being a company kicking around forever. I met Jaime Nig, the CEO, when he was like, there were 4 of them in an apartment in New York City with a cat. Actually, I don't mean a cat, but basically they were sitting there and they were slowly working away. They built a tool which could, they could give to patients in the waiting room. And slowly they enhanced that, and they added payment features on the tool. They added information on the tool. They added the interaction with the physician office. And pretty much what they were doing was having the check-in function and some informational function, the payment function, a bunch of other stuff, taking it out of the hands of the receptionist and the clerk and giving it to the patient, right? Which enabled them, once they built those interfaces, enabled people to get checked in more quickly. I've seen the reverse, though, has happened in some digital. So, for example, there's been a lot of, I don't think there's been a study, but in the recent bump up in use of telehealth under COVID, there's been a number of anecdotes of, instead of in the physical visit when a person comes to the exam room, the doctor, the nurse pops in, the assistant pops in and does the weight and the blood pressure and this, that, and the other, and the doctor pops in and has already got the information ready to go, and can do that visit pretty quickly and effectively and just talk to the patient and have the data. Whereas in telehealth, even though, because the patient couldn't go in because of COVID and danger of infection, in telehealth, they don't have that information. They sometimes have to scrap around, and maybe the patient's got a blood pressure cuff and whatever, and they have to, that is part of the visit now and extends the length of the visit. So we've got some way to go to improve some of those. However, more and more people are going to find that there are remote monitoring tools. There are a couple of companies who are building kind of that front-end Swiss Army knife tool for telehealth.
Yes.
It's called TidoCare, which is another one called MedWand, who've built that kind of tool. And more and more people are going to have these things, and you're going to have more of this technology doing sensing in the home, and that probably will kind of go away. But I do understand how you bring in a new system, and it doesn't necessarily save time. And then the biggest one of the lot here has been the introduction of, which is, some people call it digital health. Bob Doctor does, it's called digital doctor. I wouldn't call it digital health, but the introduction of EMRs, which, as we know, in general, slowed doctors down, gave them more to do, and they're spending more time, as much time with the EMR as they are with the patient. Whereas many of them had got very, very good at doing, paper note shorthand. So there are lots of advantages to EMRs, but I think, it probably delayed the interface there between the doctor and the patient in a big way. Having said that, you've now got a series of companies, and of course, as a reflection of that, you have the growth of this new profession called Describe, which is some poor pre-med student wandering around, writing down everything in the background, and there's a lot of that going on. Having said that, you've got a number of companies who are now building solutions. You've got people like Suki and Robin, who are doing kind of a nuance, who are kind of trying to take the verbal conversation and make sense out of it, make that the electronic medical record part, and really and sort of get the interface of the EMR out of the way. And you've got the company called, I'm blank on it, but they have the Google Glass, which has the scribe sitting in Pakistan over the system. It's not Agamatrix. What is the name of it? I am blanking on the name. I'll remember it when we skip to the next question. But they have Google Glass, and it's being used. They've raised over $100 million, and they are Information gets presented back to the doctor in their Google Glass, but also there's a scribe in the background able to write up, is listening and writing up what's going on, and that's where that seems to again take a lot of the clunky interface out of the way and improve the experience. So I think it's all over the map. Somebody said Augmetics in the chat. Thank you very much. It is Augmetics. What's worse, there are two Augmetics. There's one called Augmetics with a CS, which is the Google Glass sort of scribe company. There's one called Augmetics with an X, which is an Israeli company, which has got kind of a weird view into augmented reality for surgery. I've talked to both of them, and they both said the other one should change their name.
So COVID-19 has made it crystal clear that understanding the social determinants of health is an integral part of healthcare delivery. So how can digital technologies help in capturing and analyzing social determinants of health data better than the traditional approaches for analyzing this data?
Whoa. Well, I mean, there's a lot that can be done with digital health regarding social determinants of health, both on the analysis side and on the actual sort of getting stuff done side.
Mm-hmm.
So I think, if you go back, there's been a lot of discussion for years in the health service research community about how, zip code is health is a function of zip code, and we know the impact of education and housing and this, that, and the other one on health, and obviously the impact of physical nutrition, diet, and then things like substance abuse, et cetera, et cetera, et cetera. So we can do a lot more tracking people's health as a consequence of their life, basically their life circumstances, and we can start to do stuff about their life circumstances. But I think the obvious things that we can do, there are companies like Unite Us and others who are essentially plugged into the EMR, so that when a healthcare provider, physician, clinician, organization has somebody with a particular problem in front of them, they can now prescribe solutions that are not just medical solutions. And it might be housing, it might be reference to social work, it might be reference to food banks, all that kind of stuff. In fact, Jacob, we talked about upstate New York earlier, Jacob Ryder, who used to be at ONC, way back, was deputy national director for a long time, is running he's actually put together an IPA, independent practice organization, which is not of doctors, but of all these social service agencies, and they're using Unite Us, the technology, as a backbone for for those folks, so that you can actually, if you appear at any one of those, you might appear at a housing shelter or a food bank or whatever it is, they can refer you back into medical care, and the medical care will refer you back. So it's all like one referring system. So I think there's a lot that can be done. On the analysis side, the data side, we're getting very good at figuring out what works and what doesn't work, and who needs what intervention. So I think there's a lot of tools being delivered there across the board. Even Palantir, which is going public these days, was involved in this at one point, looking at sort of things like infections and the spread of disease and the spread of things like, which are not really social determinants of health, but things like salmonella outbreaks and food, because they can track across multiple vectors in a way that probably wasn't done before. I don't know if there is such a thing as a solution for this, because you've had companies like Esri, which did geographic information systems for years, looking at the access to providers, looking at access to hospitals, looking at access to food deserts and all the rest of it. At some point, you've got to have, it's like we said before, Nicholas, we've got to have some kind of policy intervention, right? At some point, you've got to decide that we're not going to spend money in the emergency room, we're going to spend money in housing. You have even seen organizations like United Health Group and Kaiser Permanente actually spend money directly on housing for people who are consistently, who are homeless, who are consistently showing up in their emergency rooms, costing a lot of money. It's not entirely clear that this kind of approach is that either this is the right thing for the healthcare system we're doing, rather than a more general government approach, or whether this is as effective as people thought it was going to be. The hot spotters trial in Camden, New Jersey, actually showed it wasn't that effective in terms of saving money. Even though getting at and using sort of social services to try and stop the people coming to the emergency room actually wasn't that effective, or didn't reduce hospitalizations that much. Although people go back and forth about whether that was the way that was set up, or whether it's been set up better in other areas, etc. But this is part of a bigger realization we're just coming to. The healthcare system is actually part of society. These things impact each other, and we've got a way to go. And as we mentioned, there are back earlier, there are a bunch of, for political reasons, we don't connect a bunch of the healthcare system to each other, let alone it to the wider society.
Exactly. So let me ask you a question concerning the Veterans Administration. So currently about 80% of the medications, including, very critical medications like for blood pressure, diabetes, heart disease, are still sent to veterans by U.S. mail. Is this because of provider or patient reluctance, or any other reason, like a government regulation?
As opposed to what?
Instead of being administered to veterans by mail, it's basically being administered on site.
So on not being sent by mail.
Yes.
Okay.
Yes. Yeah. Sorry.
Well, I see. So not 80% being sent by mail, but 80% are not.
Yeah, that's right, or not.
Yeah. Well, ignoring for the moment the fact that whether the mail service is going to work or not. If you have that, you just showed your screen, Nick. I don't know if you wanted to do that.
I don't. Let me just enlarge this.
All right, I'll keep talking while this is going on.
Yes, here.
So ignoring the fact that the post office may, for political reasons, may not be working as well as it was, and that discussion obviously is irrelevant. It's not caused by healthcare. You've seen over the last few decades a tremendous growth of the mail and mail order being used for routine chronic drugs. And the other thing you're seeing is much more recent, but the growth of both mail-based but also other forms of delivery-based drugs. So you've seen companies like Alta Pharmacy, which has got now several cities, started in San Francisco, which is actually is now delivering by messenger bike or whatever, delivering by FedEx or whatever else, delivering medications that way so even meds that are prescribed the same day, can be delivered the same day rather than having to wait for it to go through a PBM system or what have you, mail order. So I don't know why the VA. I didn't realize the VA wasn't, taking this uptake as much. I don't know if there was an issue with whether problems tracking the people involved or what have you. But it seems to me that the places we're going in that area, you've just seen Amazon talk about, it's not Amazon, Walmart again, talk about using drones for drug delivery, using some of the technologies that have been quite successful in things like places like Africa. Rwanda, which companies like Zipline have been doing drone-based delivery of medications. And I think we mentioned Amazon before. They're likely to do they're very likely to, they already have PillPack, which is a delivery of a drug delivery system with the drugs included to the home. So, I think that's an option. You might see more of that. So I don't know why the VA is where the VA is. I haven't looked into that specifically, but it seems to me that a combination of getting the stuff you need to people at their home and the tools and the coaching that they need to figure out how to do it is going to grow dramatically. One of the things that I've seen is the increase in sort of hospital at home. Mayo Clinic just did a deal with a company called Medically Home, which is doing exactly that. And they bring a ton of stuff into the home. oxygen supplies, technology, farm medications, whatever is needed, right? And they found it's cheaper doing that than spending the money, or than having hospital admissions, because there's so much capital intensity in hospitals. Hospitals have to charge so much, and they're able to cut some of that out and do it at the margin. So the general trend is towards more widespread distribution. And then if you go down the path, I mean, this is now science fiction, but with the spread of 3D printing, we're going to be printing a lot more of these things at home and delivering there'll be much more distribution of supplies. The way that you're starting to see in energy, right, where people are now producing energy on site with solar panels and that kind of stuff, rather than central generation. This is going to be the trend of the next few decades. Exactly how it plays out in healthcare, I'm not sure.
No, I agree with you, Matthew. So what steps should healthcare organizations take to digitally engage patients to better and in a less transactional manner in the post-pandemic era?
So I have a short answer and a long answer here.
Okay.
Short answer is that the healthcare organizations are getting better, but they're still rooted in general. Most of them, plans and others, are rooted in the sort of the customer service technology of the 1990s or the 1980s, and they need to sort of start thinking about allowing more multi-channels, social media, chats. And we mentioned using chatbots, but it can be for admin and customer service as well as for remote care, but remote patient care. But you've got some companies, and I pick one like Conversa Health, which is now being used by Northwell in New York, or by Long Island, or by UCSF in San Francisco, where they've been doing kind of symptom checking using a bot, but a very good conversational written and message interface, which works very well, and then can put you up to the level of, so, do you have COVID symptoms? Well, the machine can make a determination about that, talking to you, and then it can put you up into a channel of talking to a human being, and then maybe get you admitted. So that kind of level of customer service is going to come. The long answer is something I've been pimping for a while, which is called that we've got to develop what I'm calling the continuous clinic. And I started calling it the Plicimo. And then my friend and colleague Jester Massa started telling me that that's a stupid name because it doesn't mean anything. But Plicimo actually describes what it is, which is the patient location independent, clear, care integration management organization, right? So what does that mean? That means all the stuff we've been talking about, all the remote monitoring, the sensing devices, the delivery of the stuff, whether it be pills, whatever, to the home to manage patients, the tracking and the coaching and the telehealth back and forth with the patient regarding the let's say they have COVID and one of the devices is a pulse ox and their blood oxygen dips. You need to be able to immediately, ping them on their devices and get through to them automatically. And there's some technical tricks in that as well. And then you need an infrastructure around that, which is measuring all the stuff that's coming back, measuring all the data that's coming. We talked about measuring data from individual patients. Because in general, most patients, so take a look at companies like a Livongo, which is working on doing, managing people with diabetes, and they're taking the data from blood glucose meters, and a coach will give somebody a call if somebody's blood glucose is way out of whack and say, okay, looks like you're out of whack. You need to, take a bit of insulin, or you need to eat a bit of food, or whatever the solution is, or, can we help with this? And there's a combination of coaching in the minute and then more general behavior change coaching, right? Based on the flow up and down of how their blood glucose is doing. Now, if you take that and go that across the board, say, what are the other things? We have blood pressure, blood glucose, pulse, ox, temperature, et cetera, et cetera, et cetera. Of all this stuff. Some people, who are relatively healthy, don't have any problems, we should be checking in on things like weight and whatever over time, but, it's not. There are some people who need a lot of intensive monitoring like they would get in the hospital, almost to the ICU level. This is a sort of medically home, hospital home concept. And for what we need is a system where we're taking in all this data, and instead of everyone being monitored for everything, because, the average, I could do my blood pressure 5 times a day. It's not going to be very helpful for a primary care doc. But for the people who do need it, who are way out of range, who need help, we need to have intelligent care pathways and AI and algorithms to figure out, yeah, we've got to intervene with this person, that person. And
That's right.
We need a staff there. We need an tech-augmented staff who can then say, yeah, now I'm going to do a telehealth visit now, or I'm going to intervene here with some coaching, or I'm going to send a human being to their house because they need it right now, or I'm going to send someone to their house to take them to a hospital. Exactly. And if we had that in place for COVID, we could have managed without getting so many people in the hospital, and we could have had less hospital infection, and we could have had people who were sent home from the ER because they weren't admitted for whatever reason.
Exactly.
We could have saved a lot of lives that way. So I think, you can argue, I'd argue that if you really want to do patient engagement, you've got to be able to do real deep patient engagement outside the facility. And this goes back to the question that we were talking about earlier, which is, who runs this, right? Is this the role of a hospital? Is this the role of a health plan? Is this the role of a new organization, this continuous clinic that I call it, which doesn't really exist now? And that's a question, does Amazon do this? That's a question. That's a question we haven't answered yet, right?
No, and people still with telehealth, it has its advantages. But like I said before, it's bringing back that old fashioned where the doctor used to make a visit to your house, going back to the 50s and 60s. The next question is going to be a multi-part. With digital solutions, it seems that during COVID-19, the largest segments of the American population that have been very hard hit has been Hispanic and African American communities. We could talk about socioeconomic issues, etc., lack of health care, particularly in the cities. So what is your perspective, particularly when we're looking at today's technology, hence telehealth and machine learning, to really accelerate preventative medicine, being proactive? And can this technology address the challenges faced by not just Hispanic and African American communities, but also what about the baby boomers that are becoming probably the largest healthcare population to address in terms of their needs?
Wow, okay, a lot in that. So I think there are some obvious things to say. We have an extremely unequal society, which reflects in our healthcare system. Exactly. I have my daughter's former pediatrician is an amazing pediatrician called Nadine Burke-Harris, who's now the Surgeon General of California, first ever one. And she ran a clinic in the Bayview, Hunters Point area of San Francisco, which is the small part of San Francisco that isn't wealthy. That has a lot of Hispanic and African American populations. And she was very, she ended up running a center before she was Governor General. Her main talk was the ACEs study, which Kaiser did back in San Diego way back when, which was the
yes, I remember that.
Which is the study looking at adverse clinical factors that impact you.
Exactly.
And these tend to be heavier among we're all subject to some of them, but these tend to be worse. These types of factors, such as not having a parent in the house, having a parent in jail, having alcohol or drug prison,
family composition, and
whatever, all that stuff, right? The more of these you have, the more likely it is that you have various health conditions from a young age, including things that you would think of, like heart disease and stuff. It's based on this. And a lot of this is to do with stuff that we know about in terms of stress and the impact of stress on health as a whole. Is there's a reason that Dean Ornish, when he had that whole when he built his own heart disease practice of reversing the heart disease without surgery, was implying that meditation and diet and a sense of Zen really helps you. There's a reason that we have this kind of mental health stuff around, because this stuff is bad for you. Excessive stress and bad for you. And we know the impact of things like financial problems, divorce, living in unsafe areas, etc., on that. So some of this is connected to that. Some of this is connected to historic racism, which we have to dive into, but it's been a big part of America since 1619, if not before.
Well, it's a
Hasn't gone away.
conglomerate of, yes.
All the way to last night. With
Exactly.
in the conversation, right? So all these things come together, and then a lot of it is the way that people, people of the BPOC community has been historically treated in hospitals by medical professionals has been different, and the whole issue of the concept that for instance black women have much worse maternal mortality rates. Even somebody as wealthy and successful and prominent as Serena Williams nearly died, not due to lack of money, but as an example of the problems we've had. So all this stuff wraps up. I don't know if digital technology in and of itself can do much other than it can spotlight, and communicate about these issues.
That's
and
right.
be used as a way to get more access to more people. Because I think that originally we talked, and this is kind of true, not so much for the baby boomers, but with the generation that went before them, the greatest generation, that there was a reticence of those folks to use, and maybe of lower income people to get access to this technology. But I think with smartphones and the adoption of smartphones by folks like Greg Hall and Best Buy to older people, and the fact that the smartphone is now cheap and generic, and you can find them for $50, $30 on the street in India, and they're available for $100 at Best Buy now. You'd have to buy a $1,000 iPhone. To my mind, a lot of this access to the digital technology is going to improve, and it's not going to get rid of the other big structural problems in society, but it's something we can use to help.
Exactly, and to me, it's needed. But besides digital health, all the capabilities to be able to leverage machine learning, even at a distance, deep learning.
Absolutely.
Yes. Yeah. So Matthew, it was great speaking with you. What I would like to do is open it up to a couple questions. We may go over by 5 minutes. And so let me go to the Q&A session. And we have a question that says, this is, the gentleman's name is Akins Amo. He says, my organization will be very grateful to have a detailed conversation with OSP in order to develop its software system for an impending project.
Look at that, you got a lead out of the webinar, wasn't
Yeah.
I'll tell Akins, thank you, I'll take my 10% on that.
Okay. The next one is from Vanessa McCarthy. As the healthcare industry is shifting to the value-based healthcare model, that is true. I've heard that term used many times. Do you think digital health platforms will benefit providers or result in revenue losses, as patients may not feel an emotional connection through these platforms? What do you think? I have my own opinion, but what do you think?
That's a good question. Do we
it is.
More or less? I think as it ripples through, it's slow to happen. What actually happens in most other industries is that when you get a change in the technology delivery system, you end up with different players profiting.
Yes.
Obviously, it's the Amazon effect. If you look at what happened to the stock price of Sears and Macy's and all those other companies, while Amazon was coming, you see different people. Probably the whole thing goes up, but it's different people. And I think the emotional connection is largely gone anyway. Now, people, I think, can be replaced. But if you talk to Marcus Osborne at Walmart, he'll say that when they surveyed their consumers, why did Walmart think that it could develop primary care, right, without a brand, without personal connection, whatever, without a brand in primary care? Well, the reason is because they surveyed their population, and of 30% of the people walking in the door had no primary care doctor. So they had no emotional connection with a primary care doctor because they didn't have one. Then half of the other 60, so 50%, so the next first, so total of 60, couldn't name, said they had a primary care doctor, but couldn't name him or her. Yeah. Hadn't seen him in 3 years. So in other words, 60% of them didn't really have an emotional care. So most people going to Walmart big chunk of Americans don't have an emotional connection. I would also say that you can enhance your emotional connection or your integrated connection. I mean, I'm a member of One Medical. They charge you $150 a year to sign up to get them. One of the things you get is email and voice and video communication, kind of when you want it. And I actually get, my doctor, who I know decently well, emails me back and forth. I have a bit of an emotional connection with him. He happens to be their medical director as well, which is random. And so we spend most of our time talking about technology and not enough to talking about my health. I'm blaming him. I'm happy to blame him for my poor health, but the point is, we go back and forth, and he'll send me an email saying, "Hey, I didn't see you this recently, and have you been eating those cookies? And you go running, and so I think, and he does that without me seeing him in person, but I see him out socially or at conferences more than I see him in his office. So it goes both ways. My guess is that it'll be different people, and overall, the money flow will be the same, but it'll change.
Exactly. This is the last question. A major challenge in healthcare access. This is by Jeff Henderson, rather. So a major challenge in the healthcare access, even in urban areas, is the lack of services and skilled specialists. Can technology address this issue? Well, I think we've been discussing that. It's the whole basis of digital health. So what's your opinion?
I think this
Matthew.
is one that will be. I think it's one that will be cracked, because I think there's access to specialist care, specialist opinion. There are companies like Rubicon MD and Arista and others who just do that, who have a sort of store and forward technology, which does spreading pretty fast. And I think pretty much it'll be relatively standard now to go to if the primary care doctor says you should get a specialty referral, to actually for them to do it right then and there, to have this, the question go off and have the answer come back like a lab test and come back in 24 hours, or maybe even have them directly on the Kaiser does this directly by video. They'll call down the hall or down across town to a specialist and get an opinion and consult right there. And the concept of waiting and trying to get into a specialty appointment, I think that will go away, because the other thing that's got to change here is the access to is doing telehealth and specialty consults across state lines, and that's been suspended under COVID, and I think that will change as well.
Exactly, and there's been talk about to address urban areas, but particularly rural areas, having some sort of similar to a Peace Corps that President Kennedy started, but to have it domestically administered, and in the meantime help to ease the tuition costs to help students get through medical school. So the more physicians that we raise, particularly specialists, will help. Again, Matthew, I cannot say thank you enough. I learned a lot from you. So we come to the conclusion of this webinar. Thank you for sharing your point of view, Matthew, and thank you for all for joining in. Hope you found this webinar very useful. I know I did. Please feel free to subscribe to receive updates on our up and coming webinars. Again, thank you, everybody. And Matthew, thank you very much. Take care.
Thanks. It was a pleasure. Thank you.